In today's objectives, the learner should be able to define SEERS, sepsis, severe sepsis, and septic shock, identify all possible organ dysfunction related to the development of severe sepsis, learn the CMS sepsis care bundles, and remember the important documentation requirements. So let's begin. What is sepsis? Commonly, we would think sepsis is just an infection, but it's actually more than that. Sepsis is the body's overwhelming and life-threatening response to infection that can lead to tissue damage, organ failure, and death. In other words, it is your body's overactive and toxic response to infection. According to statistics, sepsis is the #1 cause of hospitalization. We spend about $62 billion each year for acute sepsis hospitalization and skilled nursing care, an additional $3.5 billion on sepsis readmission. Approximately 30% of patients diagnosed with severe sepsis do not survive, and up to 50% of sepsis survivors suffers from post-sepsis syndrome. Needless to state, when it comes to sepsis, time matters. By now, you should be asking yourself, how do I identify these patients early? Don't worry, we will go over that in the next few minutes. SEERS, or Systemic Inflammatory Response Syndrome, may be the first physiological changes you may observe, and these are hyperthermia, or temperature greater than 100.9 degrees Fahrenheit or 38.3 degrees Celsius, hypothermia, or temperature less than 96.8 degrees Fahrenheit or 36 degrees Celsius, tachypnea, or respiratory rate greater than 20, tachycardia, or heart rate greater than 90, and other abnormal lab values, which includes WBC more than 12,000, WBC less than 4,000, and bands greater than 10%. Now that we went over SEERS, when does it become sepsis? The clinical definition of sepsis is having 2 SEERS and a possible source of infection. Here, we listed some of the most common possible sources. However, keep in mind that sources of infection are not limited to this list. And these are cellulitis, burns, wounds, pressure ulcer, meningitis, pneumonia, pancreatitis, appendicitis, infectious diarrhea, gallbladder infection, intra-abdominal abscess, urinary tract infection, endometritis, chorioamnionitis, or any existing indwelling catheter. Always assess for any catheter-related infection or other bloodstream infections. Now, what is severe sepsis? Severe sepsis is having sepsis plus an end organ damage. In other words, the patient now has 2 SEERS, a source of infection, and now organs are involved. At this time, the patient may present with systolic blood pressure less than 90, systolic blood pressure decrease of greater than 40 millimeters mercury, MAP less than 65, acute altered level of consciousness or sudden confusion, acute respiratory failure requiring mechanical ventilation or BiPAP, decrease in urine output less than 0.5 ml per kilogram per hour for 2 hours, and abnormal lab values not related to chronic illnesses or medications. These are your INR greater than 1.5, PTT greater than 60, total bili greater than 2, platelet less than 100K, creatinine greater than 2, and lactic acid greater than 2. Now, what is septic shock? We need to identify septic shock early because the mortality rate increases by 50%. By definition, septic shock is when the patient have a severe sepsis plus persistent hypotension within an hour of completion of the 30 ml per kilogram IV crystalloid bolus, or if lactic acid is greater than or equal to 4. Thankfully, the CMS has provided guidelines on how to treat sepsis early. Part of the 3-hour bundle includes measuring lactic level by using lactic acid with reflex to repeat order, obtaining blood culture before giving any antibiotics to identify the causative organism, administering the fastest antibiotics within 3 hours of earliest recognition time, administering 30 ml per kilogram crystalloids in the event of initial hypotension, or if lactate is greater than or equal to 4. As part of the 6-hour bundle, we need to repeat lactate collection if initial lactate is greater than 2. Also, we need to start vasopressors for persistent hypotension after administration of crystalloids. Now, there are also some important documentation requirements. We need to document vital signs every 15 minutes for 1 hour post-crystalloid infusion, and the physician needs to document septic shock reevaluation. Let's go over the antibiotic table. As previously mentioned, it is important to administer antibiotics within 3 hours of severe sepsis or septic shock earliest recognition time. Always consider giving the antibiotics that have the shortest duration. To name a few, the most common antibiotics you may see is ceftriaxone, levaquin, axipim, unacin, or sozin. I hope you enjoyed this module and good luck on your post-test. Thank you for listening.